Welcome everyone to the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, October the 15th. So thanks everyone for joining. On the call with me today, let's see here from the STS side, we've got myself and Emily Conrad, Carol Crone. We have our consultants, Chastity and Leslie, Nancy, Banu, Dr. Jacobs, Melinda, and Paul are on. So thanks everyone for being on the call with me today. In terms of our agenda, I just have a super brief STS update, and we also have a quick presentation by Paul for utilization of the STS help desk. We're going to save that to the end of today's call. After the STS update, we're going to hop over to the data manager education with Chastity and Leslie. They have quite a bit of content to get to today. So we'll start with the education, and then if we have time at the end, then we'll circle back and touch on the utilization of the STS help desk from Paul. And per usual, we'll finish today's call with our Q&A. So if you have questions, please be sure to put those into the Q&A. We do have that raised hand function enabled. So please be sure, if you do use the raise hand function, make sure your microphone is enabled on your end. And yeah, just be sure to put all of those questions into the Q&A. All right, so let's go ahead and hop into our STS updates. The October training manual is posted and available. If you had checked the STS website over the last week or so, it stated that it was updated as of, it was still reflecting September, updated as of September, but just know that the training manual, the October training manual is posted, and marketing did just correct the STS website to state that it was been updated for October. So again, just know that the October training manual is posted, and the FAQ summary is posted as well out there and available to you. The STS Data Manager Collaborative is now open. And again, to learn more about the Data Manager Collaborative, previously known as the STS Mentorship Program, please review the August 13th webinar. I have included a link to that webinar from August the 13th. Addie gave a phenomenal presentation about the Data Manager Collaborative. So if you would like to go back and revisit and learn more about that program, please use that link there. Also, for all of our social media people, our Facebook people, we do have a STS Data Manager STS Data Manager Facebook group. So if you would like to join our Data Manager Facebook group, please, I think Carol, could you put a link to that into the chat about the STS Data Manager Facebook group? Please note that this group is strictly for marketing purposes. There is no discussion of data definitions, anything like that. It is just strictly for marketing purposes and to connect with other data managers, or strictly for networking purposes and to connect with other data managers. We have a few questions for you to answer when you request to join, so please answer those questions. That'll get you admitted to the group a lot faster, so we don't have to go and look you up. But again, if you are on Facebook, please request to join our Facebook page. We'd love to have you join our group. The fall 24 harvest update, the data is finishing being packaged up by IQVIA and will be headed back over to STS for analysis the end of this week, the beginning of next week. Again, that will include the surgery dates of July 1, 2020 through June 30th of 2024. And the report release date, of course, I'll share that with you all as soon as we have it available, but probably likely looking end of November-ish, 1st of December. But again, we'll share that date with you as soon as we have it available. 2025 harvest schedule will be posted soon. You can go ahead and just anticipate those harvest close dates to stick with our current schedule, likely around the same time that you can expect the spring 25 harvest to close around the beginning to mid of April. I think we typically close around the middle of April, but those dates will be posted soon, and we'll share those with you as soon as those are available. For AQO 2024, just a friendly reminder that we do have our Hot Topics webinar coming up next week. It's scheduled for Tuesday, October the 22nd from 11 to 3 p.m. Eastern Time. If you did not register for AQO for the in-person or the virtual, and you would like to get the AQO content and as well attend the Hot Topics webinar, you can still purchase the virtual pass. You can purchase that up until November the 15th. After November the 15th, you will no longer be able to purchase that virtual content, the online content. Speaking of the AQO content, that will remain on the virtual platform until Friday, December the 13th. After Friday, December the 13th, that content will then be moved over to the STS Learning Center. So you can still access that content after December the 13th, but it'll just be moved over to a different location. The CEU deadline, please keep in mind, is Friday, December the 13th as well. For next year's AQO, please, we have not got the final location yet, but as we did mention at last year at AQO at the in-person, we're looking at this down between two places, like Chicago and New Orleans. So we don't have the final location just yet, but it will be down to those two locations. And also we'll be offering, the same platform as we did this year. We'll have the in-person as well as the virtual pass available for attendees. So we're looking forward to our Hot Topics webinar coming up next week. So please join us. Look forward to following up for Hot Topics next week. Like I said, I'm going to skip over the utilization of the STS Database help desk support. We're going to, excuse my scrolling really quickly, but we're going to hop over to our education updates from Chas and Leslie, and then I'll turn things over to you guys. Chastity, Leslie.
Thanks, Leanne. Yep, let's jump right in. So today for educational updates, we're going to go over the option to enter a limited data set for adults with congenital heart disease non-index cases. We're going to review some important definitions like index operations, episodes of care, and primary procedures, and then we're going to go through some case scenarios. Next slide. Okay, without further ado, next slide. If you were a part of AQO, you kind of heard this teased by Dr. Nelson, but we will be offering an optional ability to enter a limited data set on non-index cases for adults with congenital heart disease. Next slide. So just some background on how this came along. There was recognition by many people that the data burden for version 623 was much too high, especially for patients over the age of 18 or 75 days. Multiple ideas were kind of tossed around, and the request was made to limit the fields entered prior to a version upgrade. The task force reviewed these requests and ideas, and they approved reducing the required fields for non-index adult cases down to about 22 fields. And we'll get into why that's about in the next few slides. Next slide. Okay, so what's not changing? Next slide. All cases done by your surgeon, by a surgeon on your Schedule A, are still going to be entered regardless of the patient's age, which procedures they have done, or the op type. All fields on all index operations are still required, and you are still required to submit all cases within the harvest window. Next slide. And then what's optional? Next slide. Okay. So we're gonna, for adults with congenital heart disease, when you enter a case, so that means if the patient is over 18 for the date of surgery, sites can choose to enter all of the extra fields, or they can stick with this limited data set. But it's important that you talk to your team, your surgeon, anyone else who shares your data to determine if you can go down to the strictly limited set, if there's other things they want you to enter that they might use locally, to determine a start date for doing this. And as always, our recommendation is that you document the process, document what fields you're going to be collecting and not collecting, and document your start date, so it's easier for you to look at your data in the future. Next slide. Next slide again. It's also important to remember that this is not an official version change. So there's no changes coming to your software, regardless of which software you use or direct data entry. There's nothing happening there. And there are no updates or new reports from IQVIA. So what that means is if you choose to enter this limited data set for these non-index cases, there's no way for us to know when you submit those cases that it's not a field that you wanted to enter and just forgot versus a field on a non-index case. Next slide. Next slide again, sorry. Okay, and then also to be aware of some harvest challenges. So because nothing's updating, you will need to utilize the existing filters in the IQVIA platform or your own software to reduce noise. So some reports do have a filter for index versus non-index that will help. And then also it's very important to understand the inclusion criteria for each report. So for example, the missing this report is op type 1 and 2, not just index. So you'll need to be aware of him only entering limited data on non-indexes, even if it's op type 1 or 2, etc. And those criteria can be found in that giant Excel spreadsheet on the website. We can go through where to find that later. Next slide. Okay, so we'll get into what exactly the fields are that we want to keep versus what's optional. Next slide. So for the administrative section, your participant ID is going to be required for every single case. That's what kind of gets you into the bucket for submission for your hospital or your surgeon group. Those trial questions are optional. For demographics, every patient must have at least one demographics record entered. So every patient, usually it's going to be your index operation, but you're going to start your file with this demographic record, right? Your patient information, name, date of birth, address, all of these things. That will be entered once. So then for a non-index, you do not have to update that. But if you only have non-index cases, you still will need to enter demographic information one time. Birth information will operate very similar to the demographic address and patient information, needs to be entered once. And then in the future, you do not need to enter that. Next slide. Okay, the next three sections, non-cardiac, congenital, anatomic abnormalities, chromosomal abnormalities, and syndromes. Again, just like your demographics, these all fall in the demographic table, and therefore they're entered one time, and you don't have to enter them again for your non-index operations. Next slide. Into the hospitalization, the fields that will remain required for every case, index or non-index, are hospital name, hospital NPI, admit date, surgery date, height, and weight. And you'll notice a lot of these are risk model variables, and we need to keep those to make sure that all cases are a complete record when submitted. And then what are required, but they're calculated in your software, are a calculated BMI, BSA, and the age in days at the time of surgery. Keep in mind that if you enter kind of part of this information and you go back, depending on how your software works, you might have to kind of retab to get those calculations to run, but it is important that those are submitted as well. Next slide. Preoperative factors, preoperative labs and tests, and preoperative medications. All of these are optional on non-index cases for adults with congenital heart disease. Next slide. Important to note that for preoperative factors, you can leave this blank, but doing so puts you at risk of kind of falling in those at-risk emails at the time of harvest. So you have the option of leaving it blank. You obviously have the option of entering any pre-op factors that you want, or you could also select yes, select other, and free text in non-index op. That is completely up to you and your program and how you want to handle those. But because we send those emails and it's based on missing fields in the risk model and others, if you had a ton of non-index adult cases, you might kind of push that threshold. So keep that in mind. Next slide. For diagnosis, you do need to enter the primary diagnosis of the operation. And then, of course, your fundamental also lives on that demographic record that lives with the patient. So it'll be entered one time, but you do not need to go back and review for non-index cases. Moving down, the valve-specific diagnostic information is optional. Your status post information is optional. And the hemodynamics, cath, and echo information is optional. Next slide. On to procedures. Again, you do need to have a primary procedure indicated for a non-index operation. You do not, however, need to enter procedure-specific factors or ECMO procedure information. Again, talk to your programs because it's very possible that your non-index operation may be ECMO and your program might want that ECMO information. So it's optional as far as STS is concerned, but make sure you have a conversation with your team to know what they, still might want to get out of this locally. Next slide. For the operative section, the things that will be required on non-index cases are procedure location, status, operation type, surgeon, and surgeon NPI. Everything else optional on this. And then into the specific procedures, CABG, your valve specific, non-cardiac, other non-cardiac, AFib, VAD, and aorta. My favorite is that aorta is optional for non-index. Again, all optional. And again, we're going to be a broken record, but talk to your teams about what they may or may not want in these sections. Next slide. Post-operative section. Required. Patient expired in OR. This is required because we have programmed logic that if that is yes, for any case, it flags that it could be a mortality. So that does need to be answered yes or no for every case, index or not index. Your post-operative events, optional. Next slide. Okay, discharge and readmission. There's a lot here that is still required, of course, because this is what all ends your episode of care. So whether or not your patient is still in the hospital discharge date, hospital discharge status, end of database discharge tracking, status at the end of database discharge tracking, mortality at 30 days, the method in which you verified their mortality status at 30 days, and whether or not the case is an operative mortality. Again, required, but calculated, database discharge date and database discharge status. Next slide. Maybe. We try next slide again. Perfect. Okay, so we just wanted to spend one quick moment just reviewing this right here and make sure that everyone understands these are required regardless of op type for non-index adult cases. Because as we know, mortality is calculated based on status at 30 days, even if it's status at 30 days of a non-index case, if it's op type 1 or 2. So these fields, status at 30 days, method in which you verified that, and whether or not it's an operative mortality are all required for non-index cases as well. Next slide.
Oh, sorry.
That's okay. Okay, longitudinal follow-up. Again, this lives on the demographics record, so it'll be entered one time. That doesn't need to be entered for every subsequent case, but if your entire record is made up of non-index, you will need to enter that at least once. And then patient process measures are optional. Next slide. Okay, shifting gears really quickly, we just wanted to review.
Sorry, I'm having.
Okay, you can go to the next one. Perfect. No worries. These are going to be really, really important to understand as a data manager because this is all going to fall on our ability to identify the correct index operation if we want to only enter limited data on non-index, right? You need to know what is your index. in order to know what's your non-index. So starting with episode of care, we've been over this a lot. The time period a patient is admitting preceding and or following an operation through database discharge date. Next slide. And just as a clue for everyone, all of your events are linked by database discharge date. So whether if you're at my hospital and now they go to your hospital and they come back to my hospital, they've never gone home, all of my events are going to have the same discharge date. That's all one episode of care. So all events that have the same database discharge date are within the same episode of care. Next slide. Okay, index operation, the first cardiac case of the episode of care. So that's op type 1 or 2. Your index is not going to be anything other than a case which is op type 1 or 2. CPV cardiovascular or no CPV cardiovascular. Next slide. And then of course, primary procedure. This is the procedure with the highest stat mortality score of an operation considering all rules and exceptions. You are only required to enter the primary procedure. So really whatever you enter is going to be the primary procedure of that event. But locally, if you want to use this data, it is important to make sure that you're identifying the correct procedure so that it makes sense when you look this up later. Next slide. Okay, we're going to turn it over to Chess to go through some case scenarios with all of these new rules.
Excellent, Leslie, thank you. Okay, so let's go through a couple of different scenarios that could happen to your adult patients that come into your facility utilizing this new optional limited data set for these patients. So in our scenario number 1, a 28-year-old patient who has status post-TET repair as a child returns for a conduit placement. Post-operatively, the patient experiences a cardiac arrest, requires ECMO cannulation, and ultimately a VAD was placed. A heart transplant was performed, and the patient discharged home 60 days post-conduit placement. Next slide. So question 1, the detail of the case scenario remains up top of the slide, but let's look at the question. Which procedure is the patient's index operation? Is it A, ECMO cannulation as it was the first operation performed, or B, conduit placement as it was the first CPV cardiovascular or no CPV cardiovascular case performed? Is it the heart transplant because it did have the highest stat score, or is it none? This patient did not undergo an index operation. I'll give you a few minutes to answer this in the poll.
Let's see.
All right, so that's about 30 seconds. We think we're okay.
Yeah, I'm gonna go ahead and end it
In the poll.
and share results.
Did it go on the next slide? Oh, there we go. Okay. So the correct answer is the conduit placement, because as Leslie already said in her presentation, the definition of an index operation is the first cardiac operation, which means op type 1 or 2. And straight from your training manual definition, it refers to the first operation in the episode of care where the op type is 1 CPV cardiovascular or 2 no CPV cardiovascular. So your conduit placement in this scenario is your index operation. Next slide. Okay, so same scenario, next question. For the conduit placement, which we have now correctly identified as the index operation, my site can determine which optional fields to collect for this patient. Is this a true statement or a false statement? Okay, I think we can end it there, Leanne, and share the results. So some of you did say this was a true statement. The correct answer here is actually that this is false, because the conduit placement is the index operation. And as Leslie said in her slide presentation, that the index operations still require the full data set. So you will still, you will not collect the optional limited data set for the index operation. Next slide. So question 3 for the same scenario, this patient has new genetic testing results available. They were not available at the time of their original childhood TOF repair. So how should this now be handled in the database? Is it A, go ahead and update the results in the demographic record for this patient, or B, there's no need to include the new results in the demographic record? Okay, Leanne. And we'll share the results. So 96% of you did answer this correctly, that you are going to go ahead and update the results in the demographic record. This is because this patient is undergoing an index operation along with other non-index operations. But because there's an analyzable index operation, you do want your demographic record to be as complete and accurate as possible. So you would go ahead and update these new genetic testing results that were not available previously in the new demographic record. Next slide. For the non-index operations performed, which of the following is optional to collect and enter into the database? Is it the primary diagnosis and primary procedure? Is it the operation type? Are they the postoperative events? Or is it the surgery date? Okay, Leanne, I think we're good there.
You got a pretty good grasp on this one.
Yeah, so correct. The postoperative events were optional to collect on the non-index operation. And of course, you're going to continue to collect them on the index operation in this scenario. Next slide.
Oopsie, sorry about that.
And yes, I think I said exactly the answer. Don't worry. The post-op events are optional, but on the index operation, it would not be optional. Okay, so same scenario. Next question is, a program wants to review their patients that require mechanical circulatory support prior to receiving their heart transplant. How is this handled in the database? Is it A, this data is not available in the database? B, the data is no longer collected if the transplant is not the index operation? Or C, a program can continue to collect any of the optional fields? You're pretty good there, Leanne. I think we can stop it.
I think we're good there.
So 100% of you said a program can continue to collect any of the optional fields, and you are absolutely correct on that. The non-index adult congenital heart disease limited data set is optional. So you can continue to collect a full data set on any of the operations or just the fields that are needed or wanted by your program. Absolutely. Next question. Same scenario, just question number 6. I only need to complete the mortality fields on index operations. True, this data is not used in the analysis, or false, the mortality field data must be completed on every operation. Okay, I think we can stop there.
Yeah.
98% of you have said the correct answer, which is false. The mortality field data must be completed on every operation. And Leslie then again highlighted this in her presentation as well, but for your reference, the mortality fields are collected on all operations, and these are listed through the slides that Leslie presented, and then also listed here, including if the patient has expired, the mortality date is also required. So these will be answered on all operations, regardless of whether they are the index or non-index case, and regardless of the operation type or patient age. Next slide. Which operation should the preoperative factor diabetes get coded? Is it, it can be coded on all operations, but it's required on the conduit placement. The program can decide which operations to code diabetes on, or it's important to include this on the transplant operation only. I think that's pretty good, Liam.
Yes, ma'am.
Okay, so 100% of you answered it correctly. It can be coded on any one of the operations, but of course is required on the conduit placement, which is your index operation. So all fields for the index operation are still required. Next slide. Okay, so this is our scenario number 2 for our optional limited data set for non-index adult cases. This is a 20-year-old patient with a history of TOF repair at your facility and arrives with hemodynamic instability. Cardiac surgery cannulates the patient for ECMO. Unfortunately, the patient experiences a stroke and care is withdrawn. So this will set up our next handful of questions. Does this patient have an index operation during this episode of care? Yes, because all patients have an index operation in the database, or no, this patient did not have an index operation. All right, Leanne, I think we're good there. So it looks like 86% of you answered this correctly. The patient did not have an index operation. So not all patients will have an index operation during their episodes of care. Some patients come in and do not have an operation that is op type 1 CPV cardiovascular or op type 2 no CPV cardiovascular, and therefore they do not have an index operation. So in this scenario, the patient was cannulated for ECMO only, which is not op type 1 or 2, and therefore this patient does not have an index operation. Next slide. Do you enter the ECMO cannulation into the database? The answers are no, the patient did not have an index operation, or yes, all operations performed by a cardiac surgeon on your Schedule A should be entered. Okay, that's probably a good place to stop. As Leslie said, all operations performed by a cardiac surgeon that's listed on your Schedule A should be entered into the database, regardless of age, procedure, or op type. So a patient that does not have an index operation and perhaps only undergoes something like ECMO cannulation does get entered into the database. Next slide. The patient's existing demographic record in your database is version 341. Is it required to update this? Yes or no?
Good question.
It's a tricky one. I didn't mean it to be tricky, honestly, but we get this question a lot, especially right before harvest.
Yeah.
All right, this is a good place to stop. It's tricky, and that's why you're at 50-50 in your responses. So technically, you are not required to update your demographic record on your patients as long as their demographic version is 3.22 or greater. So there are programs, mine, for example, as a rule, we always update our demographic record to be the most new in the database or most relevant in the database, because new fields get added and such, and those, of course, many of the fields in the demographic record are analyzed and used in the risk model. So we personally, as our program, want the demographic record to be as accurate, as complete as possible, and we update ours. However, there are programs that don't want to update their demographic record, and as long as you have a demographic record that is 3.22 or greater, that is not a problem in the database. So in this scenario, you didn't have to do it, but you may choose to do it. Next slide. The patient required intubation and underwent CPR prior to the ECMO cannulation. Should these be coded as preoperative factors? Yes, all preoperative factors should be coded on all cases, or no, it is up to the program whether to capture preoperative factors on a non-indexed ACHD operation. Okay, Leanne, that's probably a good place to stop. So 74% of you said it is up to the program whether or not they want to capture the preoperative factors on a non-index adult congenital operation, and that is the correct answer. Remember, as Leslie pointed out, so this will get reported as missing and could knock you over into the threshold to receive one of the at-risk emails right before harvest. So to prevent this from happening, under preoperative factors, you can select yes, select other, and then free text in something like non-index operation in that field. That way it's not missing. you're not saying no. You can also, it's fair game to leave it blank. Just if you do a lot of reoperations that are of op type 1 or 2 on an adult patient, then it could throw you into that threshold. And so that's why we came up with this way, so it wouldn't do that for you. But it is up to the program whether or not you want to capture the preoperative factors. They are optional on the non-index adult operations. Next slide. Okay, this is scenario number 3. A 20-year-old patient with undiagnosed congenital heart disease, they have no previous surgical history, arrives with hemodynamic instability. Cardiac surgery again cannulates this patient for ECMO, they experience a stroke, and they withdraw care on the patient. Does this non-index operation get entered into the database? Yes, all cases are entered, or no, it's not an analyzed case. Okay, I think this is a good place to stop. This is a repeat question, just worded in a different way. Remember, all cases done by a surgeon that are listed on your Schedule A are to be entered into the database, whether it is an index operation or not, regardless of op type, procedure, and age. So yes, this case would be entered into your database. Next slide. Can I code the preoperative factor 230, shock persistent at the time of surgery? Yes, it's required to code all preoperative factors. No, the patient doesn't meet the definition for shock. Or yes, if the program wants to collect preoperative factors on non-index adult operations and the patient does meet the definition for shock present at the time of surgery. Okay, probably a good place to stop. So this took me back to nursing school. When you pick the answer that's the longest is always the correct one. So that is the correct answer here. If the program wants to collect preoperative factors on non-index adult operations and that factor definition is met as specified in the training manual, then yes, a program can collect it. It is not required on the non-index adult congenital operations. Next slide. This patient has never had any operation at my facility. How do I handle their non-cardiac anatomic abnormalities, their chromosome abnormalities, and their syndromes? Do I complete a demographic for the record for this patient? Do I leave the demographic fields blank? Complete the other demographic fields, but NCAA, Chrome ab, and syndromes are optional, so they can be left blank.
Another good one, Jess.
Another good one, right?
Mm-hmm.
I think that's a good place to
Oh,
stop.
yeah.
So as Leslie said in her presentation, you do need for each patient to have a completed demographic record in the database. So in this instance, this patient has never ever been to your facility, unlike the previous almost same patient that had a previous TOF repair and had a demographic record that was already completed. You could leave that alone. But in this case, where this patient has no history, no enter into your database whatsoever, you are going to have to go ahead and complete a demographic record for this patient. And so you want to fill those out to make it as accurate and as complete as possible. When I upload my file to IQVIA, the missing variable report shows the optional fields is missing. So how do I handle this? IQVIA should be updating their report following this change. Understand that there will just be more missing fields reported, or STS will require your vendor to create a report. Okay, probably a good place to stop. We seem pretty stable. So yes, as Leslie has said, and I will say again, there are going to be more missing fields reported. And so that is true within the IQVIA reports, or perhaps even any reports that your vendor has in their software as well. This is an optional fix for right now because we can't do a version upgrade right now and require IQVIA or vendors to make any changes. So if you're going to do this, you have to know that there are going to be more missing fields reported in the missing variable report. Next slide. Next slide is just in summary. So again, this is optional for programs to choose to collect a limited data set for non-index adult congenital operations. So you can go back and talk with your team, your surgeons, and figure out if you are or not going to opt to do this for those non-index adult only operations. Remember that the IQVIA missing variable report will still report all missing data. They have no idea that you have opted to not collect certain fields on the non-index adult operations. So we would ask you to pay attention to the required fields regardless of the operation type. And I did see this question in the chat about the training manual. So the go live is now. So starting right now, you have this presentation. It'll get posted shortly this week. And you can go ahead and start doing this with your cases, your adult cases now. The training manual won't roll out until that first week of November. And yes, all of this information will be included there. We will include one comprehensive list of all of the fields that are optional in this limited data set for non-index adult operations. We are not going to go field by field by field and put in that statement. We are going to have one box related to this whole ordeal. And so we'll make sure that we appropriately point that out to you in the training manual and in the supplemental document that comes out with the training manual each month. So we're happy to take any questions.
Yep. Yeah, let's tackle these questions before we go to help desk stuff if we have time. So our first question from Dawn, do any centers have vendor software that doesn't already carry over demographic fields? Trying to understand how.
Hey, Leanne, can I jump in on this one?
Yes, sir. I figured you could, Paul.
Yeah, I have seen several questions like this, and I just wanted to kind of clarify. Vendor software is set up to have one demographic record, period. So as soon as you get a patient, first thing you have to do is fill out the demographic record. That demographic record follows all of your operation records. You don't have to do anything. That's already done automatically for you. As long as you have it filled in for any of the procedures that were done for this patient, it's there. You don't have to re-enter anything for that. It's all following that patient. If it's a new patient, you do have to enter all of that information in. And so that does include NCAA, chrome abnormalities, and syndromes. If you're doing direct data entry, I know that the IQVIA platform has a button where you say, I've already got a record for this patient, and I want to create another record for that same patient and copy some of that data over. So I think that gets done for you there as well. I honestly, I'm not 100% sure what fields are included in that and how that exactly works. I believe it's all the demographic information though. So the whole demographic part might be a non-issue for you. So that's the way the vendor software works. So just wanted to throw that out there.
Thank you, Paul. Excellent.
Okay. Another question from Dawn. Mortality, operative death, sequence 4985. We have historically entered this only on the index procedure record and not the subsequent procedures non-indexed. Many of our internal dashboards, queries, reports depend on this process. What will happen at IQVIA if we continue this practice?
Yep, I can take this one, Leanne. So the short answer is that is out of compliance, I guess, so to speak. That's not the definition of operative death. It should and always, as far as I know, have been entered on every single case, regardless of op type, which has been in the training manual. I don't think that field is specifically looked at IQVIA as a filter in any way. However, all of these cases that we submit to STS are not just for the purpose of getting a report, an analyzed report. A lot of these data are used in research projects by many, many institutions nationally. We benchmark against them. And if you have cases in there, which don't happen to be your index, and it says not an operative mortality, although it is, that would be incorrect. So the short answer is you should be entering this on every single case.
And Leslie, correct me if I'm wrong, is operative mortality, operative death an audited field?
I
Don't think so.
No, okay,
Not sequence 4985, no.
okay.
And then Abby had some warnings showing up in IQVIA when her demographics version was 341, when the patient had fetal drug exposure and entered as a syndrome. Told by IQVIA that I should update the demographic version in order to get rid of this warning. I think it's due to the fact that this field moved from a syndrome to a pregnancy complication. And that is correct.
Yeah, I can jump
ahead,
in there
Paul.
too. Yeah,
Yep.
that's yeah, that is a that exact situation is a prime example of some incompatibility between the way the 341 data is, and because we got rid of so many tables and stuff going to 623, and the way the data is being handled in the database, there's some incompatibility for just a handful of the codes. So if you have an old demographic record and a new operation record, some data can show up, be reported as missing when you actually have a value. And it's because the old code isn't compatible with anything new and we can't map it over. So it is, so like Chastity was saying earlier about, like, you don't have to update your demographic record, but it really clears things out and really helps a lot. So I would recommend doing that whenever you can. Go ahead and update your demographic record to the newer version. That clears up a lot of issues.
And then Terry, if the operation is a pacer generator change in the abdominal rectus, is this still considered op-type non-CPB cardiovascular? Think Chastity?
Terry, yep, absolutely, you're correct. All pacemaker procedures are op-type no CPB cardiovascular, unless they happen to be done on bypass, in which case they would be op-type CPB cardiovascular. But otherwise, if you did a generator change, it is op-type no CPB cardiovascular. And if that's the only procedure done, it would be your index operation. Correct. And yes, Elizabeth, this webinar will get posted to the STS website. It's usually sometime this week or early next week that it gets posted. Leanne, am I correct about that?
Yeah, you're right. We'll send the recording over to our marketing team and they have to curate it and do all that magic stuff and get it ready for posting. So at the latest, it'll be the 1st of next week. And then let's see here. L Henderson too had their hand up. I've unmuted you if you wanted to ask your question. I don't know if you still had a question or accidentally raised your hand, but not sure.
That's my Linda.
Oh.
No question here. I'm not sure
You're just raising your hand for fun.
no, I didn't even have my clicker there. I don't know why it went up.
Okay, I lowered it. There you go.
It's a cat that sits on her desktop.
Ren, I think Dawn had a comment. Ren had a comment for you. She added an index column on the spreadsheet that feeds their internal dashboard. She'll have to manually complete this column after the weekly data pull, but it can be filtered on their Tableau dashboard. This allows me to complete all STS fields. Not sure if that helps. That's great info, Ren. Thank you. And Dawn says thanks. Paul, we've got I think we have enough time to cover those help desk slides if you wanted to.
Yeah, I think I can get through it pretty quickly.
Yeah.
Okay, so we just wanted to kind of give everybody an update on like the best way for you to interact with help desk and who to send the messages to and what sort of information to put in your requests. Next slide.
Yes.
Okay, so there's 3 main help desks that you can send emails to. The primary one is this one, STSDB_helpdesk at sts.org. That is what we globally refer to as help desk. And that is for any sort of questions that you have if you have trouble with your login, you need your password reset, you're getting logged in, but you're not getting to the reports you think you should be getting to. If you have any questions about your data submissions, if your data quality report's showing errors that you don't understand, or anything's going on there, you're having trouble getting your files uploaded, all of those questions come to this help desk. Questions about your reports. If you have trouble, if you think your vendor's doing something they're not supposed to, we can help you with that. If you have questions about your vendor software, that has to go to your vendor, because we don't know anything about the vendor software. But we can help you if you're having troubles with your vendor. Red cap questions come to this help desk. And basically, if you're not sure where to send your question, send it to this one. We're happy to forward it on to whoever should be handling that question, if we're not taking care of it ourselves. But that will cover about 90% of the questions. And so that's the best place to send it. All right, next slide. All right, the other two are STSDB at sts.org. That is the one for your official business. So anything involving your contracts, if you want to change something about your contract, if you want to start contributing to the anesthesia module and getting the anesthesia reports, anything like that, any questions about invoices, anything dealing with money, that goes to the official business database or the help desk. That's STSDB at sts.org. And then there's also the frequently asked questions, STSDB_FAQ at sts.org. That is for your clinical questions. If you get out onto the STS portal, under the data managers help section, there's a form there that technically does send it to this mailbox. It asks you all the questions to help you make sure you're providing all of the information that we need. But this is all for clinical questions, like you've got a patient that you're not sure how to code. You're not quite sure what the definition means and how it applies to one of your patients or something like that. Or if you have questions about the data specs or the training manual, that all goes to the FAQ help desk. All right, next question or next slide. All right, so whichever help desk you're going to, it's really important that you communicate with us effectively. And so for the most part, you want to be clear and concise and to the point. More information helps us figure out what the problem is and what issue you're having. But when we get gobs of information that doesn't apply to anything, it just takes up time to have to weed through to find out what exactly is the issue that you're having. So for starters, you want to make sure that you include all the important information, primarily who you are. Your participant ID is critical, because we don't want to be talking to somebody who's not even participating in the database and taking up time away from our members. If you're having trouble with NPIs, your surgeon NPIs, anesthesiologist NPIs, you're getting records rejected because those aren't matching and you don't understand why, tell us the NPI, tell us the surgeon's name, who's having the problem and stuff like that. So that sort of detail, you want to make sure that you get all of that included. And then also your subject line is very important, because that is kind of used as a title to the issue that you're having. We have a bunch of utilities that we use for keeping track of all this information. And also it helps us to know which ones need to be handed off to a different group or to a different person. And we have different people within the help desk tend to work in certain areas. And so we want to be able to tell by your subject line who should be handling this problem. So your subject line should be, just think of it as a title, 10 words or less. You don't need to elaborate, put your whole question in the subject line. All of that should be down in the body of the email. And just kind of hit the high points of what it is. So it's something like, trouble logging in, question about my analysis report, where is this document? Something along those lines. So the other thing that helps us understand what your question is pictures. Pictures really do say 1,000 words. And so if you can get a screenshot of whatever the error message is, or the section of the report that has the number that you think is not correct, getting a screenshot of that gives us a world of information. We know exactly what you're talking about and which report you're talking about and things like that. So adding in screenshots is very useful. So I'm actually going to take over control here, and I'm going to do a real quick demo to show you how to do a screenshot, because we often get people who send us photographs of their laptops as a screenshot, and that sometimes can help us out, but when we have to blow it up to be able to see the text, a lot of times the text is just too blurry at that point, and we can't make out what your question is. So where's my share? There it is. Share that. All right, so I'm going to come over here. Leanne, can you see my screen?
Sorry, yes, sir, I couldn't get off mute.
Okay, thank you. Okay, so if I'm here and I've got, can't that go away? There we go. I'm on this screen where I've uploaded a file and I'm having this issue. I'm having an issue getting this to go away, but okay, I'll leave it there. I want to be able to see, I have an issue with uploading my file, and I'm getting this little red X here, and I don't know why. And so it really helps to send us this tile of information that's going to give us, which upload are you talking about and what is your participant ID and everything. That's all sitting right here for us. Okay, so the way you do this is you press the window. Oh, I'm sorry. The instructions I'm giving you is for if you're using Windows. If you're using a Apple product, this isn't going to help you. And I truthfully, I don't know what the code is to do that, because I use Windows. So, so if you're using Windows, you hold down the Windows key, you hold down the Shift key and the S all at the same time. So you can't see me doing this, but I'm pressing those 3 keys at the same time right now. You'll notice that my screen now goes gray, but I can still see what's on my screen. And plus I get this plus sign as a cursor. And so what you do, you go up to the top left-hand side of what you want to capture, and you click and hold the left mouse button and drag it down to the bottom right, and then just let go. And everything goes back to normal again. And what that has done is that has taken that section of the screen and put a picture of it onto my clipboard. So now if I come over to my email message where I'm sending a message to help desk, I can come over here and do either a Control V or right click and say paste. And it puts that picture in there. And, so now you can have exactly what you're talking about with the problem that you're having. You can put that into your email message and get that sent to us. And that will tell us a world of information, because, in this particular case, you're trying to figure out why there's an X up here. And what I'm seeing is that your file name is not following the correct format. And that tells me that you're getting your file from either somebody who has edited it, or it hasn't been produced by your vendor software. Something else is you're sending some other file. So, there may be things in there that you're not even aware of that's going to tell me a world of information of what's causing the problems. So screenshots always help. All right, Leanne, you want to go back to our slides?
You got it.
Okay. Okay. So, and I also want to point out that this, if you notice on this screen, when I was saying the Windows button, that's this little button here that looks like the Windows character. All right. So those are things that you should put in. Nope, go back one.
Sorry.
That's okay.
Okay.
So those are things that you should do. A couple things that you should not do. One, don't send your message to multiple help desks. Only one is going to handle it. And when you send your message to multiple help desks, all you're doing is bogging down the system, because they're going to have to deal with this message that doesn't pertain to them. So they forward it to the help desk that does pertain to them, who you've also copied on the message, and now they have too. Okay. And, you may think that you're going to get a faster response if you copy everybody and their brother on your email, but you're not. You're actually slowing things down because now we have that many more messages that we have to close out. Every time we get these email messages, we get a ticket that we need to process, make sure we're getting the right one answered, and getting the right one closed out, making sure that it's getting closed out at all. And when you send your message to multiple people, it could be that both people try answering it at different times or at the same time, as it has happened in the past. And so all you're really doing is you're creating problems with getting your questions answered. So do not send it to multiple help desks. Send it to one. Don't copy individual people. So like you have some of our personal email message addresses. Don't copy them on there. Send it to the help desk. Help desk will handle it. If we need to get input from somebody else, we'll send it off to that other person to get it sent to them as well. Don't send questions directly to IQVIA. I know that on the IQVIA platform, there's things that say, if you're having trouble, click here to send a message to the IQVIA platform. That's part of their standard package that we can't get them to turn that off. So if you have a question about what's going on the IQVIA platform, send it to the help desk, the STS help desk, because we will answer the question 90% of the time. If we can't, there's people that that's not part of IQVIA's help desk. It's part of the STS team at IQVIA that we're going to send the question to. So the only time you want to send an email to IQVIA is if they send a message directly to you and you're replying to that. So in that case, you're only replying to their email. You're not generating a new email. So that's one thing you don't want to do. Also, don't send additional emails later on to ask the same question to somebody else or to ask the same question again. Okay, go ahead and go to the next slide, Leanne. Okay, we'll skip this one. Go ahead to the next one. I think we covered that. So we usually get your emails, your questions answered within 48 hours. Technically speaking, we usually get it answered by the end of the day. Most questions get finalized by the end of the day. There's only ones where if we need additional input from other people, or it's a bigger question and we're not quite sure what's causing the problem and we have to dig into it some more, then it can go a little bit longer than the one day. Usually we will get a response back to you within 48 hours. And if we're not going to get a response back to you and an answer back to you in 48 hours, we'll send you an email and say, hey, I'm working on it. Give me a little bit of extra time, we haven't forgotten about you. So there's no need for you to send another email asking the same question, because again, that just creates another ticket that we're not sure, that could be picked up by somebody else. And now you got two people stepping on each other's work and it starts causing all kinds of problems. So, if 48 hours goes by and you haven't heard from us, then resend that same email again and just ask, can I get a status on this? So that way it has the same body of the message, the same subject line and everything else. And that's that. Next. And that's everything.
Yep, that was it, Paul. Thank you.
Okay. Yep.
Yep, and I know Carrie had her question, but she had to hop off, so we'll follow up with Carrie's question. We'll follow up with Carrie directly. But I don't know, Chas, Leslie, if you wanted to answer this for any others that may be wondering the same thing. If a patient dies 2 years after discharge, are we to go to the patient info page and enter yes for deceased, then enter the date of death in the update mortality field, just making sure we are to keep that info updated properly.
Yes, that's the most appropriate way to do that when you find out that a patient has expired, that you can go into the database and update the mortality field. Of course, we've also added now mortality status at 1 year, 2 year, 3 year, 5 year, something in those increments. And so depending on where they're at in that trajectory, you can also, and if it falls within those timeframes, you can also update those fields now as well.
And really quickly as well, to add on to that, those two fields that you're referencing, the field that says deceased and the field that says or mortality details, those are vendor specific. So for anyone who doesn't use, or those don't sound familiar to you, still go in and update the date of death in your software.
Ah, good point. Thanks,
Good
Leslie.
point, Leslie. Sorry.
That's all right.
Yep, and Brooke, is it possible to email, would it be possible for those email contact info explanations on which help desk to email be posted to the STS website or within the IQVIA platform? Banu, did you want to chime in there, or did you have something else to add?
No, nothing at this time. Thank you,
Oh,
Leanne.
sorry, I'm sorry. But yeah, so Brooke, I can get these. So this slide deck will be posted out on the STS website, under the webinars. So you can download the slides and, with these slides, the help desk information. And actually also I can pull it out and post it to the IQVIA library as well. I don't think that would be, that's, I think that would be good if we could post it out there as well. We're going to find the chart about major versus minor post-op events and the time frame. Do we have a chart about
A chart? There's just in the training manual, each one has its own distinct definition, and it lies out within each definition if it's a major or other time frame. If other people have created charts and things, they've not been done by STS proper. So I'm not sure about those.
Yeah, correct. Yeah, we haven't.
Someone nicely had this on a webinar.
I think part of AQO, I don't know if it was this year or last year, our audit team went through the
Okay.
post-operative events on the major timeline
That's
like define that. But in the training manual, we define what major timeline is and what other timeline is, and then each individual event says whether it's major or other.
yeah.
When we create extra tables and things, what happens is definitions get updated and clarified, and then we have document version control problems. And so we keep everything in one document. Therefore, we have one place to update, and we don't run into version control issues. So
yeah, the training manual is always your source of truth.
Mm-hmm.
So perfect. All right, well, we are the training manual doesn't search well. Okay.
Thank you for that feedback. We understand.
Yep. And then also just also I know it doesn't, but just to help a little bit with the navigation of the training manual, I put bookmarks in there as well. So just, I don't know if you're familiar with the bookmarks, but they are there as well. If you have not seen those before, but just to kind of help with the ease of the navigation there a little bit. Okie dokie. Thank you, Chas, Leslie, Paul, for excellent presentations. Just really, really super quickly, hold on, I'm not going to scroll through all of these slides. The upcoming webinars, our next monthly webinars are 11/19 and 12/17. So mark your calendars accordingly. And then again, our AQO Hot Topics webinar is next week for October the 22nd. It starts at 10 a.m. Central Time. So thanks everyone for being on today. I appreciate you all very much. And we will see you all on next Tuesday, I think it is the 22nd for Hot Topics. All right. Thanks everyone. I hope you guys have a great rest of your day. I appreciate you all.